Welcome back, fellow mitochondriacs. We have an exciting topic to talk about today, and that is going to be methylene blue. And, I was going through the slide deck and I was realizing that we have so much to talk about with methylene blue because it has such a historical significance. And there's just been so many proposed benefits and mechanisms to how it works. And I want to give a nice introduction to methylene blue for a variety of conditions, whether it be as an antimicrobial, it has antioxidant effects, it has mitochondrial boosting effects, and it has anti-cancer effects as well. And also, interestingly enough, has effects on neurodegenerative disorders such as Alzheimer's, Parkinson's, etc. So we're going to get into that today. And looking at the amount of slides that I have regarding methylene blue, as well as its role in photodynamic therapy for cancer, it's possible that this may be a two-parter because there's just a lot to cover. So welcome. Okay, so I think this is a good place to start, and that is to talk about methylene blue as a whole and from a historical perspective. So, methylene blue, as outlined in this paper, is the first fully man-made medicine, which has a wide variety or wide range of clinical applications. Apart from its well-known applications in surgical staining, malaria, methemoglobinemia, and the antioxidant properties of methylene blue recently brought new attention to this century-old drug. So I don't know all the names involved with it, but there was a I think it was a German physicist physician, excuse me, who was able to for the first time utilize methylene blue within, I think, starting with mice and rats and then into humans, and treated people with malaria back in like the 1880s, 1890s. And that's how it, and when they did was they actually, when they were studying it, they found that it was actually very highly concentrated in nervous tissue and brain tissue and nerves. And they called it the magic bullet. So the whole entire reason for the term magic bullet comes from methylene blue. And it said here that mitochondrial dysfunction has been observed in systemic aging that affects many different tissues, including the brain and skin. This leads to increasing oxidative stress and results in downstream phenotypes under age-related conditions. Methylene blue can bypass complex 1 and 3 activity in mitochondria and diminish oxidative stress to some degree. This review summarizes the recent studies on the application of methylene blue in treating age-related conditions, including neurodegeneration, memory loss, skin aging, and premature aging. So I've kind of taken this paper and broken it down into some key points. So methylene blue is a well-established drug, originally synthesized as a textile dye in 1876. The small molecular weight allows methylene blue to be delivered to tissues fast. Methylene blue can be reduced into leucomethylene blue and therefore can be used as an antioxidant. Methylene blue is an FDA-approved medicine and has been widely used in surgical staining, malaria, and methemoglobinemia. As a matter of fact, every ER, at least in the United States, is required to have methylene blue on hand as a treatment for methemoglobinemia. And a couple other conditions that I think are interesting that are not talked about in this particular study is that they're using, or potentially going to be using, methylene blue in refractory septic shock. And I have personally seen it used twice in that context in an ICU. According to the free radicals theory of aging, cell and tissue aging are a result of free radical attacks. In human cells, reactive oxygen species are mainly produced in the mitochondria, while aging Declines in mitochondrial mass, respiratory capacity, and respiratory efficiency were observed in different tissues. Dysfunctional mitochondria lead to decreased ATP production and increased ROS production, which would further damage mitochondria. This vicious cycle leads to severe cellular damages and accelerates the aging process. Methylene blue's antioxidant activity or properties mainly improve mitochondrial function and break the ROS mitochondrial damage cycle, which makes it a great candidate as an anti-aging drug. And later on, it's actually past the introduction, it says that about 0.4 to 4% of oxygen is partially reduced under physiologic conditions, with ROS being the byproduct. And that doesn't always mean it's bad. It's also used as signaling, remember, retrograde signaling. There are 11 sites of ROS generation in the electron transport chain. However, it is mainly produced by complex 1. Mitochondrial dysfunction can lead to oxidative damage, which primarily impairs complex 4 as well as complex 1. I'm going to have to move this out of the way just for a second here. While complex 1 is impaired, overproduction of ROS can result in oxidative stress, therefore induce cellular damage. And I dare say that from what I understand about complex 1 is that when it is dysfunctional, it will also lead to the inability for the electron transport chain supercomplexes to form well, and that ROS will also feed forward and damage the supercomplex formation as well as damaging the mitochondrial DNA, which truly makes this a vicious cycle, because when mitochondrial DNA are damaged and those key proteins for the electron transport chain are damaged as well, that will feed forward that process. So methylene blue is a phenothiazine derivative, which can also be reduced into leucomethylene blue. Methylene blue is hydrophilic and lipophilic, which makes it highly permeable through biomembranes. Methylene blue is also positively charged. The redox potential of methylene blue is 11 millivolts and can cycle readily between oxidized and reduced forms in the mitochondria because of its low redox potential, which makes it kind of like a perpetual antioxidant. As long as it's in the actual mitochondria, it can perpetually go back and forth between these forms and help the mitochondria out. Methylene blue decreases the production of ROS by bypassing complex 1 and 3 activity. Methylene blue receives electrons from NADH through complex 1, converting it to leucomethylene blue. Leucomethylene blue can directly transfer these electrons to cytochrome C, reoxidized to methylene blue. Therefore, methylene blue has the potential to protect cells against oxidative stress under pathologic conditions. And I know that's a lot of biochemical speak. We're going to look at how it actually happens very quickly. As a matter of fact, why don't we just do it right now? So this is a diagram of the proposed mechanisms of how neurodegeneration happens, Alzheimer's, Parkinson's, etc. And what they're saying here is that because cytochrome 1 is very leaky of electrons, it can readily cause reactive oxygen species and oxidative stress, which can upregulate a pro-inflammatory situation, and both the combination of oxidative stress and inflammation can lead to neurodegeneration. Okay, and this is just showing that electrons are being donated from multiple sites. Remember, it was 11 sites on the electron transport chain, on this electron transport chain, that can create reactive oxygen species. Doesn't mean all of them are bad. Remember, some of those are used, are required for signaling, but when it's in excess and we have oxidative stress, that can be pathologic and it can cause damage to various tissues. In this case, we're talking about the nerves. What methylene blue effectively does is that it can accept those electrons, those leaky electrons from complex 1, and become leucomethylene blue, and then it can actually donate that electron back to the electron transport chain to cytochrome 4, which then allows the reduction of oxygen to water and allows for ATP production. It basically essentially bypasses these proteins as a way to preserve the system. And I think that's pretty awesome. So again, as I said, has said now multiple times, Methylene blue has been widely used in surgical staining, malaria, methemoglobinemia. Additionally, methylene blue has been shown to photoinactivate bacteria in 1928 and is a potent antiviral. And its potent antiviral effects were discovered soon after. Methylene blue has been used as an antifungal, as an antiparasitic aquarium disinfectant. Even with very high doses, millimolar, methylene blue has been used in photodynamic therapy among different types of cancers, including lung cancer, breast cancer, prostate cancer. So surprisingly, a French study involving 2,500 patients treated with methylene blue and standard chemotherapy showed no cases of COVID-19 infection. I thought that was interesting. It shows its antiviral effects, and it was actually studied. You can find papers about methylene blue and coronaviruses. What I'll also say is that a study showed that low doses, 0.5 to 4 milligrams per kilogram of methylene blue are effective to stimulate mitochondrial respiration in vivo and safe in animals and humans. And that is the dose that I have routinely seen talked about by leaders in the field of studying methylene blue and neurodegenerative diseases, such as Dr. Gonzalez Lima. And so 0.4 milligrams to 4 milligrams per kilogram is a pretty important thing to remember, because we're going to talk about basically what certain doses of methylene blue can do to the serum concentration of methylene blue, which is going to be important to know the serum concentration for when the use of photodynamic therapy is employed. So oxidative metabolism is an important energy source for the brain activity. During brain aging, mitochondrial dysfunction has been associated with neuron loss or nerve loss. It has been observed in many brain diseases such as Alzheimer's disease, Parkinson's disease, and brain injuries. Methylene blue is highly lipophilic and able to effectively cross the blood-brain barrier. Methylene blue concentration is found to be higher in the brain than in the plasma after oral administration or intravenous injection into rats. Besides, it has a strong affinity of mitochondria. And in fact, it says here that the membrane potential in complex 3 inhibited mitochondria can be partially restored by methylene blue in rats and mice. Methylene blue acts as an electron donor and can increase the expression of cytochrome C oxidase and oxygen consumption in vivo. Besides, low doses of methylene blue were shown to effectively inhibit nitric oxide, which inhibits cytochrome C oxidase activity. All these properties make methylene blue a promising drug candidate. So one thing that is not shown here is that nitric oxide is a known inhibitor of complex 4 in the mitochondrial electron transport chain. And what has been shown is that methylene blue can actually liberate nitric oxide from complex 4, which also enhances electron flow and energy production. Another interesting note is that that's also one of the mechanisms of how red light works as well, is that actually will liberate nitric oxide from cytochrome C oxidase or the complex 4, and can improve mitochondrial respiration via that mechanism. So here is an interesting graphic that came along with this paper, and it basically shows that here's mitochondrial dysfunction leading to oxidative stress, mitophagy defects, altered mitochondrial dynamics. And it's interesting because there's two-way arrows, right? Because oxidative stress can damage mitochondria, mitophagy defects can damage mitochondria, altered mitochondrial dynamics, which is fission and fusion, impaired mitochondrial trafficking, neuron inflammation, dysfunctional electron transport chain, calcium imbalances. All these can damage mitochondria, and mitochondrial damage can lead to these things as well. And what they're saying here is that when methylene blue is added, it can help likely affect a lot of these systems. As you see here, this arrow is going towards all the diseases, Alzheimer's, Parkinson's, depression, traumatic brain injury, etc. And what methylene blue does is it protects the mitochondria, which ultimately leads to protections of the nervous system and the neurons that are affected by these dysfunction in mitochondria, because the neurons are so critically reliant upon energy production for their health, just like all the other tissues are too, but they're really sensitive because they require so much mitochondria. I thought this was an interesting bit of information. This is later on in that same paper. It says that methylene blue increased cytochrome C oxidase activity by 30%, and it enhanced oxygen consumption by 37 to 70%. So you see where oxygen right here, O2, is being consumed. Okay, it's being changed to water. Okay, this is the deuterium depleted water that Dr. Cruz is always talking about, made in your mitochondria. Okay, oxygen to water. This is the reason why we breathe right here, this reaction. So what it's actually doing is actually, because the activity is so upregulated and such more efficient, the amount of oxygen used in the electron transport chain is upregulated by 30 to 70%. Pretty amazing. And then the activity of this reaction here, cytochrome C oxidase, is upregulated by 30%. So pretty unbelievable. And I think it says here that which reversed premature senescence caused by hydrogen peroxide or cadmium, and the ratio of the methylene blue cytochrome C could be important for methylene blue's protective role. Interestingly, methylene blue was compared to common antioxidants used in skincare, including vitamin C, retinol. Methylene blue treated skin outperforms both of them significantly in terms of promoting cell proliferation and reducing age-related markers. So I'm not saying that anybody should be using this topically, because it's probably going to stain your skin pretty heavily, but could there be a role in anti-aging for skin for methylene blue? It seems like it outperforms the classical vitamin C retinol combinations used in skincare. I thought that was pretty interesting. So this is just another graphical representation of how methylene blue is basically cycled ad nauseum back from its kind of reduced form into its oxidized form, and it is basically carrying electrons that would have otherwise been converted into reactive oxygen species or reactive nitrogen species by the electron transport chain and its leakiness, quote unquote, leading to reactive oxygen species and oxidative stress. What it's doing is actually kind of like mopping those up. It's mopping up the exhaust, so it protects the overall system. So I think it's an amazing compound, and kind of more a clinical application is methylene blue is able to actually also upregulate the NRF2 system, which is one of the major antioxidant systems we have, or the antioxidant response elements. We talked about that. We talked about that in particular during videos about vitamin D and melatonin having their ability to upregulate this NRF2 pathway as a way to protect healthy cells, healthy mitochondria from damage. And it says here that cisplatin, which is a chemotherapeutic, caused strong damage to renal or kidney mitochondrial DNA, both in vivo and in vitro experiments. Cisplatin injections induced oxidative stress by depleting renal antioxidants at the transcriptome level, but did not increase the rate of hydrogen peroxide production when isolated mitochondria. Methylene blue, on the contrary, induced mitochondrial hydrogen peroxide production. Remember, this is why not all ROS is bad. Some reactive oxygen species actually go back and tell the nucleus to do stuff. And we suppose that methylene blue induced hydrogen peroxide production led to the activation of the NRF2 antioxidant response element signaling pathway. The consequences of activation of this signaling pathway were manifested in the increase in the expression of some antioxidant genes, which were likely cause the decrease in the amount of mitochondrial DNA damage caused by this chemotherapy medication, cisplatin. Methylene blue treatment induced the increase in expression of genes that were involved in base excision repair pathway, the main pathway for mitochondrial DNA repair as well. So it seems as if, for preventive medicine, there is a lot of possibility. I don't know if we have definitively, have the evidence that, methylene blue should be effectively added to the water. But that being said, I do think that for certain conditions, it could be immensely helpful as an antioxidant and as an antioxidant response element inducer, but also as an electron scavenger when there is mitochondrial dysfunction going on, and acting as an antioxidant to protect certain tissues, such as brain tissue and such as nervous tissue. However, the way we're going to be looking at methylene blue when we're talking about its role in cancer is actually it's actually kind of a paradoxical way of looking at it. And we're going to talk about it, how it works. So methylene blue, a promising compound for the development of developing treatments for various diseases, including viral infections, cancer, and dementia. The long history of methylene blue can be traced back to its early studies by this Paul Ehrlich on its use of tissue staining and the development of chemotherapy basics, and includes research of the use of methylene blue as an antimalarial and antidote for the toxic side effects of methemoglobinemia, cyclophosphamide, and cyanide poisoning, mostly owing to its physiochemical potential of methylene blue in redox chemistry. And before I go into the cancer side, I just want to look at other potential ways that methylene blue could be helpful as a dovetail into mitochondrial metabolic therapy. So, one of the, I would say probably one of the most difficult things that we see in metabolic therapy and trying to employ metabolic therapy for patients is that they have insulin resistance, or they have hyperglycemia, or they have frank diabetes, and it is, even for fairly healthy people, difficult to get the blood glucose levels down to the degree that it needs to get down to allow for proper ketosis, for just giving yourself the best shot against these cancers, which are highly glycolytic, or that use a lot of glucose as part of their essential metabolism, the Warburg effect, right? So what I would say is this paper was one of the only papers I could find as a way to show that methylene blue likely has an effect on blood glucose levels. It was called treatment of nitric oxide synthase inhibitor. Methylene blue moderates the decrease in serum leptin concentrations and streptozotocin induced diabetes. And this is a medication or a substance that is used in a lot of rodent studies as a way to induce diabetes, basically. And what it's saying here is that after 6 weeks of the experiments, blood glucose and glycolated hemoglobin, or hemoglobin A1C, significantly increased in basically this medication-induced diabetic group versus the controls. I mean, we're talking like quite a bit higher blood glucose, 27 versus 5 respectively. This is measured in millimoles in this particular case. And the A1C of these subjects went from 6.79 in the control group, which I don't know if it directly corresponds, because we're talking about mice and rats here, but 6.79 for humans would be considered diabetic. Anything above 6.4% is considered diabetes for humans. 5.7 to 6.4% would be pre-diabetes, and then less than 5.7% would be considered normal, although probably lower is better. But that being said, in this particular study, the control group had an A1C of 6.79%, and then when they induced the diabetes, it was 14.11%. And this increase was partially attenuated by simultaneous methylene blue treatment. And it says that instead of the blood glucose going from 5 to 27, it went from 5 to 16. So it had a pretty amazing attenuation of the blood glucose for these diabetic rats. So I do think that there's probably promise with methylene blue as being a hypoglycemic and potentially lowering blood glucose, which again, it completely dovetails into metabolic theory of cancer and the metabolic therapy for cancer by lowering the blood glucose to reduce the amount of available glucose for the cancers to suck up from the microenvironment in the bloodstream, so that they can potentially grow out of control and lead to all of their various vicious cycles. So this paper was published in January of 2024. It's called Methylene Blue Metabolic Therapy Restrains in Vivo Ovarian Tumor Growth. And it says here that in this study, we investigated the potential of methylene blue as a metabolic therapy and complementary treatment approach for ovarian cancer. Our findings demonstrated a significant in vivo reduction in the proliferation of these ovarian cancer cell lines in this preclinical study, which used carboplatin-resistant ovarian cancer. So these cancer cells were not only ovarian cancer cells, they were resistant to carboplatin chemotherapies implanted in mice. Methylene blue-mediated metabolic therapy exhibited superior tumor slowdown compared to carboplatin treatment alone. This indicates for the first time methylene blue's potential as an alternative or adjuvant treatment, especially for these chemotherapy-resistant cases. And I'm going to kind of like go into this paper a little bit. So ovarian cancer, devastating disease, highest fatality rate among all the GYN cancers. And despite advances in cancer detection and treatment, the majority of patients with epithelial ovarian cancers are diagnosed at an advanced stage and exhibit a limited response to platinum-based chemotherapies. The development of drug resistance in advanced ovarian cancer often leads to relapse and death. The current standard treatment options for platinum-resistant ovarian cancer, such as pegylated liposomal doxorubicin, paclitaxel, topocan, has been shown limited efficacy and accompanied by strong side effects. You know, I think this is a really good time to talk about one of the major reasons why these chemotherapeutics a lot of times don't have a lot of an effect is because of the vicious cycles that are set up from the Warburg effect. It's the vicious cycle set up by the lactic acid and succinic acid acidic tumor microenvironment that leads to immunotherapy, not functioning, as well as chemotherapies, as well as our own immune system. So it would make sense that a potential primary strategy in something like that would be the use of metabolic therapy as a way to get that lactate and that succinic acid down, so that way these chemotherapeutics potentially could work more effectively. And we'll talk about some of the interesting thoughts that kind of mainstream medicine has been looking at in the literature as a way to overcome chemotherapy resistance by using sodium bicarbonate. And I'm going to talk about those at a later date. But metabolic therapy effectively should decrease that tumor microenvironment as a way to help those previously resistant tumors become sensitive again, which is what we've seen kind of over and over again with various substances, including things like DCA or dichloroacetate. But I'll digress. So metabolic reprogramming has emerged as a key characteristic and hallmark of cancer cells. So the Warburg metabolism and the metabolic reprogramming that happens is a hallmark of cancer, right? Of all cancer, and including ovarian cancer, contributing to their survival and growth. And impaired mitochondrial function and an altered cellular metabolism play crucial roles in tumor progression and chemoresistance. If anybody's been tuning into the channel for any decent period of time, this is like preaching to the choir, right? We know this pretty strongly. One of the main intriguing metabolic phenomenon associated with chemoresistance in ovarian cancer is the Warburg effect and enhanced glutaminolysis. I will be very frank. This is one of the first times that I have seen, and interestingly enough, this paper was published in January of 2024, so roughly 1 year ago. So this is a pretty new paper. And I have rarely seen where researchers connect the dots of Warburg and enhanced glutaminolysis or glutamine utilization in the same sentence in a more conventional paper. But I'll digress again. The Warburg effect is characterized by increased glucose consumption and lactate production, while enhanced glutaminolysis involves the increased utilization of glutamine as a fuel source for mitochondrial respiration and, probably more importantly, biosynthetic processes. These metabolic alterations are commonly observed in various cancers, but in particularly prominent in chemoresistant ovarian cancer cells. And further down, it says that methylene blue, a well-known dye agent, and with antibacterial, antiviral, antifungal, antiparasitic activities, have shown promising effects in stimulating the mitochondrial electron transport chain and oxidative phosphorylation, leading to increased mitochondrial respiration and ATP production. It has been widely used as a strong photosensitizer for photodynamic therapy. And I think this is a interesting bit of information that we see here in this text, but also in this particular graphic, okay? So I will talk about metabolic, in future videos when talking about fatty acid inhibition for cancer cells. And what you'll routinely see is the use of hydroxycitrate with alpha lipoic acid and alpha lipoic acid with hydroxycitrate in a variety of studies and publications where they're trying to block fatty acid production that is used for, not for energy, but for biosynthesis of fatty acids for cancer cells. So if you look at how glutamine is used, at least part of the reason why glutamine is used is for biosynthesis of other molecules, macromolecules, in particular, other amino acids and fatty acids. And fatty acids, they use citrate in the electron transport chain, in the TCA cycle, as a way to be the backbone of these new fatty acids that are produced, and hydroxycitrate has been shown to block the key enzyme in that process. And so this has been shown in several studies to be effective against a variety of cancers by itself, the lipoic acid and hydroxycitrate combination, or metablock. But in this paper, they actually use methylene blue plus metablock, and they look at how it affects both normal ovarian cells as well as these carboplatin resistant or chemotherapy resistant ovarian cancer cells as well. And they're looking at their effects on the actual amount of the cancer cells that can actually grow basically in these cultures. And so this is what they call a cell proliferation assay, right? And so it says here that methylene blue metabolic therapy exerted a strong inhibitory effect on the proliferation of these ovarian cancer cells, where the cell proliferation reached 16% of the control group. So the control is 100% growth, right? And when methylene blue was added to these ovarian cancer cells, it dropped from 100% down to 16%. So significant halting of their growth, right? And we can hypothesize why that is. There's probably multiple mechanisms at play, but one of the main reasons is that it likely shuts down the Warburg effect, and that Warburg effect is what's necessary for the uncontrolled growth. The sensitivity of these ovarian cancer cells to MBE50 compared to the normal epithelial cells highlights the potential of methylene blue as a therapeutic agent for targeting ovarian cancer cells metabolism. It is also noteworthy that methylene blue has a significantly greater inhibitory effect on the proliferation of these cells compared to cisplatin, 16% versus 29% respectively. So here we have methylene blue lowering from 100% down to 16%, and cisplatin lowering from 100% to 29%. So it's effectively more effective than chemotherapy in this particular study, and looking at it from this particular way, which is the uncontrolled cell growth or the cell proliferation. And then later on, I found this graph fairly interesting. So we have the tumor volume. Okay, this is tumor volume, and it's looking at days. Okay, this is 0, 4, 9, 24 days, and we see here that this is like the control group. It just continues to grow uncontrollably, and then here's carboplatin with very minimal, decreases in growth. So let's just try to estimate here. Let's say this is a 2,500 millimeters cubed in terms of the tumor volume. And then when we add methylene blue plus that metablock, right, the alpha lipoic acid hydroxycitrate combination, we see even a stronger, than carboplatin. Okay, in terms of its tumor volume, it goes down to about 2100. It looks like, and then methylene blue alone is this here, and it has actually the most effect on. It has more of an effect than even methylene blue plus this metabolic or metablock, excuse me. It's less than 2000 in terms of the volume. And then the strongest actually effect in this particular study was methylene blue plus carboplatin. So, again, we're looking at carboplatin resistant ovarian cancer cells. So it would be, understood that you're not going to have the same response that you would have if these were sensitive to carboplatin. But what you see here is a synergistic effect between methylene blue, a slight synergistic effect between methylene blue and carboplatin, likely meaning, to me at least, when I'm looking at this, that there's probably an unlocking of that resistance. And my bet is that the unlocking of the resistance, at least partially, is going to be the fact that methylene blue is going to increase reactive oxygen species within these cancer cells, effectively enhancing apoptosis, but also likely shutting down to some degree the Warburg effect and allowing carboplatin potentially to get into the cells easier. That's my hypothesis looking at this. So this is the next paper I want to look at is looking at, again, methylene blue in the context of neurodegenerative diseases and cancers. So we've already kind of talked about how methylene blue has effects on Alzheimer's, Parkinson's, other neurodegenerative diseases, but we haven't talked about its effect on GBM. And it says here, on the other hand, cancers, including GBM or glioblastoma multiforme, have increased glucose uptake and rely on aerobic glycolysis, aka the Warburg effect, for metabolism. The switch of highly efficient oxidative phosphorylation to lowly efficient aerobic glycolysis, the Warburg effect, provides macromolecule for biosynthesis and proliferation. So basically, to reiterate, the Warburg effect effectively makes these cancer cells immortal, right? And it makes them grow out of control. And it gives them the substrates necessary, proteins, carbohydrates, fatty acids, for cell division and for growth. And so that's no different for these GBM cells, right? And current research suggests that methylene blue, a centriole drug, can receive electrons from NADH in the presence of complex 1, and it donates to cytochrome C, providing an alternate electron transport. We've already talked about that. We've seen the graphs, etc. Methylene blue increases oxygen consumption, decreases glycolysis, and increases glucose uptake in vitro. Methylene blue enhances glucose uptake and regional cerebral blood flow in rats upon acute treatment. In addition, methylene blue provides a protective effect in neurons and these astrocytes against various insults in vivo and Alzheimer's, Parkinson's, Huntington's disease models. Yes, but in glioblastoma cells, methylene blue reverses Warburg effect by enhancing mitochondrial oxidative phosphorylation, arresting glioma cells, and inhibits glioma cell proliferation. So kind of what I was referring to as a potential way of why there's synergy between chemotherapy and methylene blue is the fact that methylene blue is effectively, at least in some part, shutting down the Warburg effect. And that is also confirmed by this paper talking about glioblastoma multiforme. And knowing what we know about methylene blue in prior slides, showing that it has a high affinity to nervous system tissue and it has a high ability to cross the blood-brain barrier, it would make sense that methylene blue could be employed as a possible effective strategy alone for glioblastoma multiforme. And in this other paper, it's saying that reversing the Warburg effect as a treatment for glioblastoma. And, just to reiterate, the Warburg effect was discovered by Otto Warburg in like the 1920s, 30s, et cetera, right? He won a Nobel Prize or multiple Nobel Prizes. The Warburg effect has been known for many, many years. And Seyfried, picked up the torch a long time ago as well, talking about this. And so, this paper is fairly old. It's published in 2013. And, they're talking about reversing the Warburg effect for glioblastoma. So we've known about this abnormalities in metabolism of cancer for a long time. And it's just interesting to see these papers being published and just really getting not a lot of traction. But I'll digress. Glioblastoma multiforme, like most cancers, possess the unique bioenergetic state of aerobic glycolysis, also known as the Warburg effect. Here, we documented that methylene blue reverses the Warburg effect, evidenced by increasing oxygen consumption and reduction of lactate production in these glioblastoma multiforme cell lines. Later on, it says that human GBM xenograft model, a single daily dose of methylene blue does not activate AMP kinase or AMP activated protein kinase signaling, and no tumor regression was observed. In summary, the current study provides the first in vitro proof of concept that reversal of Warburg effect might be a novel therapy for GBM. And so let's just take a look. And again, these are in vitro studies, but here's a control group, and we have amount of colonies per well. Here is how they're documenting this, and there's a variety of various treatments, that are being employed. So here's the control group. Here's temozolomide, which is the standard chemotherapy medication used for GBM, and then we see here that 100 nanomoles of methylene blue is added, and we see kind of not a whole lot of difference here. And then we see that when 100 nanomoles of methylene blue plus the same dose of temozolomide is added, we see a synergistic effect and a slightly improved effect. And then you see here that at 1 micromole, so we're talking about I think 1,000, at least 100-fold. I think it's 1,000-fold difference in methylene blue concentration. We see a giant decrease from its, so concentration of these medications does matter a lot, and that's why I want you to think about and put in your mind the 0.5 to 4 milligram per kilogram dosing for methylene blue, excuse me. And then we see here at 1 micromole, so the same concentration of that plus TMZ, again, the same TMZ or temozolomide dose, we see basically a non-existent amount of GBM cells in these wells. And then 10 micromoles, so they even 10x that. And again, non-existent GBM, and then 10 plus the 200, also nothing, right? So we see a dose response curve and a synergy between the standard of care temozolomide as well and methylene blue. And likely, again, methylene blue is reversing the Warburg effect. It is allowing for the reinitiation of apoptosis, likely, as we've seen in several other models, whether it be dichloroacetate, whether it be thymine, whether it be alpha lipoic acid, whether it be melatonin, etc. It restores the electron flow through broken mitochondria, which then ultimately leads to the restoration of programmed cell death, which is a major way that mitochondria contribute to the health of the cell. It actually can set off programmed cell death. And when mitochondria are being inhibited and being downregulated by the Warburg effect and by hypoxia factors, that's when we have basically we lose that ability. Let's see here. This is the colony size, and we see a very similar thing where we see this is the colony size of cancer cells, measured in millimeters, and we see a very similar effect on these cancer cells at the respective doses and concentrations and combinations of these medications. So we're already about 45 minutes in. I'm just wondering if we should continue on or if we should hit methylene blue and its use in photodynamic therapy in another video. And I'm gonna leave it open to the audience. Do we want to keep going, or do we want to do this in another video? Let me see here. Probably have another at least 11 slides to go over. So let me look at some of these comments while I'm waiting for somebody to answer me about whether we should continue or not. Yeah, in terms of books and resources online for details about methylene blue, I always would just push you towards the medical published literature. PubMed is available to everyone, and it's free in most cases. The papers are available for download. The high quality graphics that come from all these lectures that I'm putting up come from the medical literature themselves. Does methylene blue affect brain imagery such as MRI or PET-CT? That I don't know. My gut says that yes, it probably would, because if it is affecting the Warburg effect and affecting regional glucose uptake in the healthy cells, then I would say that it probably would affect PET-CT. Probably not MR. Interesting. You have more exercise efficiency with using methylene blue. Potassium bicarb. Actually, believe it or not, what they've been using. Someone asked, what about potassium bicarb? In some of the studies, I've seen potassium bicarbonate used in some of the studies to help neutralize tumor microenvironment. Thank you for your videos. You have helped me stop my mother's lung cancer for 7 months now. Wow, I'm so happy to hear that. That's unbelievable. Send me an email about the case study. I'd love to hear more about it. Helps reduce acidification of the cell. Basically, if you're reducing the Warburg effect, you would have less lactate available for acidification of the cell and the tumor microenvironment, which shuts down our own immune system as well as therapy. Can't wait till we go over glucose inhibition. We will go over it. We have a whole probably macro series on glucose inhibition. And I'll be talking about that after this methylene blue photodynamic therapy kind of kicks off. Chat's not working. Sorry, that I don't have any control over. Another video, 11 slides, keep going. All right, I guess we got a 1-1 saying keep going or not. I'd like to know if methylene blue helps ER breast cancer if combined with a red light panel. Great question. Keep going, please. All right, let's do it. Let's keep going. We got more people saying keep going than less, so let's do it. So this paper is titled Methylene Blue in Photodynamic Therapy, from Basic Mechanisms to Clinical Applications. And it says here, we concluded that used together with recently developed continuous light source RL50, methylene blue has potential to treat a variety of cancerous and non-cancerous diseases with low toxicity and no side effects. That sounds pretty good. You know, I guess, who was that guy? That Hippocrates guy said that we should do no harm, right? So I guess no side effects sounds pretty good to me. So it says here that photodynamic therapy, PDT, is a promising modality for the management of various tumors and non-malignant diseases based on a combination of photosensitizers, PS, and selectively localized to the target tissue and illumination of the lesion with visible light. Not always, it can be also invisible light. We've seen PDT used with UV and infrared, but I'll digress, resulting in photodamage and subsequent cell death. Numerous worldwide clinical trials have shown PDT represents an effective and safe modality for a variety or various malignant conditions. This is just going over what we went over the entire first time, looking at how photodynamic therapy works. First, it works on virtually all types of cancers, lacking the specificity of chemotherapeutics and radiation. The procedure can be repeated several times if needed, because there are no cumulative toxic effects, and it is usually an outpatient procedure. Can we let that sink in for a minute? It works on virtually all cancer types. It can be repeated several times if needed, because there are no cumulative effects, and can be done as an outpatient. I mean, sign me up if I had it. My God. In 1978, Dougherty et al. Published results from 113 tumors from 25 patients treated with hematoporphyrin derivative with complete response of 98 of the 113 tumors, an 86.72 response. Cutaneous and subcutaneous recurrent and metastatic tumors which had not responded to conventional treatment like basal cell, malignant melanoma, chondrosarcoma, colonic adenocarcinoma, prostate, mycofungus or mycosis fungoides, endometrial carcinoma, breast carcinoma, angiosarcoma, and squamous cell carcinoma were submitted or actually had an effect. There was an effect with PDT, where the conventional treatments did not. In general, a single treatment or fractionated treatments were used. Let's see here. I gotta give the whole story, right? Worldwide, thousands of patients have been undergoing PDT therapy for the past 20 years, but most trials have involved only a few patients and not have been sufficiently convincing of the benefits of PDT to be added to the standard of care. So because they're not using hardly any patients, probably because no one can make any money off of this, even though we have an 86.72% response rate in some of these trials, there's not convincing evidence that PDT can be used as a standard of care. Let's see here. We've talked about several of the drugs used, but I want to skip down here towards the bottom. And it says that the drugs in PDT are generally given systemically, but both intratumoral injection and topical applications are possible. For photosensitizers to be clinically useful, it should be non-toxic, selectively taken up and or retained in the malignant tissue, and activated by penetrating light greater than 600 nanometers to relatively photochemically efficient. So this reminds me that one of the goals I have set, my friend and also a colleague who works with me, who's a nurse, I've set him on the goal of obtaining a light engineer who did the study with Dr. Russell Reeder on the use of infrared light and sunlight on the increasing of melatonin. And his name's Scott Zimmerman, and he's a brilliant, kind of light engineer, and he's been doing a lot of he's been working with biology. And the reason why I want to get him on the channel, probably for one of my first podcast kind of style interviews, is that one of the big controversies with photodynamic therapy is that there is a lack of tissue depth at the most effective kind of biologic window in the red and near infrared range. Conventionally, it's been shown to only penetrate tissue up to 1 centimeter, okay, or 10 millimeters. And there is controversy to that because, light engineers like Scott Zimmerman, as well as, one of my mentors, Dr. Jack Cruz, push back that the effects can be seen upwards of 10 to 30 centimeters into the body with some of these red and near infrared frequencies. And so therefore, some of the pushback that I've gotten on this channel in particular is that, because there's such little penetration of red and infrared light according to conventional kind of publications, then it gives us a limited efficacy, right, of basically this therapy being employed for people who don't have basically surface level tumors or cancers, right? Like they're talking about here, some of these skin cancers like basal cell carcinoma, melanoma, etc. So my point is that I'd like to get Scott on the channel as a way to kind of debunk some of the conventional thought processes about the penetration of red and infrared light, as a way to basically give a little more hope when in terms of the use of photodynamic therapy in cancer as a whole, aside from its effects with methylene blue. So let me continue on here. So the penetration of light tumor of the tumor depth is dependent on the characteristics of the tissue being treated and the absorption of the endogenous chromophores and the use of the photosensitizing drug. Wavelengths shorter than 600 nanometers, so that would be less than red light basically, are absorbed mainly by hemoglobin, whereas vibration overtones of water and molecular molecules induce absorption wavelengths longer than 950 restrict the therapeutic window. So let me break that down a little bit. So the different colors of light will be absorbed by different things in the body. Okay, so what they're saying is that the majority of the wavelengths shorter than 600 nanometers, or a lot of it, will be absorbed by hemoglobin, and it will not allow for the photons to be used effectively for the treatment goal, right, of participating in photodynamic therapy. On the contrast, technically 950 is still considered near infrared. It's on the upper end of near infrared, but longer near infrared, as well as longer than 950, as well as mid infrared and far infrared, they are highly absorbed by water. As a matter of fact, we talked about during the photobiomodulation talk about Gerald Pollack's work and how water is absorbing highly the infrared radiation to create the exclusion zones and the coherent domains found in the cell. So, it doesn't mean that those wavelengths are useless for human physiology. God forbid. No, that's not what I'm saying, or what this paper is even saying. It's saying that we have a biologic or therapeutic window between 600 nanometers and 950, and that is where the light is the most effective at penetrating the body. And I just wanted to digress with that because it also, because we talked about a lot of different photosensitive chemicals in the prior videos, and we also talked about how some of those are UV or blue light or green light affected. And knowing this about light and its effect on the human body or just biological tissues, it makes us maybe select certain or preferentially select certain photosensitive chemicals that are going to participate in these wavelengths, right? So this is why I believe methylene blue could be the superior, photosensitive chemical. I'm going to show you that based off of this graph right here. So this graph right here shows the absorption of light by methylene blue. Okay, it starts at 500 nanometers, and it goes all the way up to 750 nanometers. But the peaks are at 600, right where red starts, and at about 670. Okay, so when we are able to shine LEDs, and if you have to understand, most of these LEDs that are shined by photobiomodulation devices are going to have usually 4 wavelengths. Okay, they're going to have 2 in the red, like 630 and 670, or 650 and 670, and they're going to have 2 in the near infrared, like 810 and 850. So at least the red portion of a light panel could have profound effects on the photoactivation of methylene blue. So let me go back to the slide where we were leaving off on. So I thought this was also important. So the light dose usually given in joules per centimeter squared is empirical and varies widely. But for interstitial applications, radiant exposures between 100 and 400 joules per centimeter squared are needed. So this is where you really do need someone who knows what they're talking about to help you with this, because and there's inherent problems. And if I do have Scott Zimmerman on, he'll kind of also talk about the inherent problems of the way that we measure a dose of light, but I'll digress off of that. So my point is that this means that the irradiance of the red light therapy device has to be a certain amount, and that's measured in milliwatts per centimeter squared, and then it has to be a certain distance away. So the distance away from the panel, right, can affect the irradiance, and then it also is a function of time, and that is a calculated value to figure out how many joules per centimeter square you're actually getting for that particular application and that exposure. So it would be beneficial to work with someone who has a clue about this stuff, to figure out what the particular dose would be beneficial for you, for your particular condition. And I'll be honest with you, this is not exactly settled science, and it's not exactly like completely worked out. This is kind of the edge of science, and we're kind of like still figuring a lot of this out. But this is what, according to this paper, is normally needed for an application. And it says methylene blue has been shown in vivo activity against several types of tumors when locally injected and illuminated with a red laser light. In this case, they're using laser. Orth and co-authors have demonstrated the intratumoral effect of 1% methylene blue, followed by elimination of this argon pumped dye laser that it emanated 665 nanometers. And again, just to like reiterate, 665 nanometers is right around here, right? So that's like pretty close to its max absorption, which is probably why they picked that particular laser light for methylene blue to be effective. And it said here that, let's see here, a radiance of 100 milliwatts per centimeter squared. So this is the irradiance, or the strength of the light, okay? And then the dose of the light is measured in joules per centimeter squared, was able to kill these xenotransplanted tumors in animals of recurrent esophageal tumors in patients. So there is a lot of potential here. Okay. Now, let's just say hypothetically that, the conventional wisdom about the penetrance of red and infrared light is limited to 1 centimeter in the body. Then that just means that more innovation needs to be done. So does that mean for this particular tumor type of esophageal cancer, they could not just inject methylene blue locally to the tumor or intravenously to the patient and then have like an endoscopy procedure where they stick it, just like we do in an upper endoscopy for looking for ulcers or looking for, a variety of conditions, could they not have a light, a red light, either LED or laser attached to that endoscopy probe that then is able to shine directly on the tumor and cause this effect, or what if it's a colon cancer? Could it not be, a colonoscopy procedure where that probe has an infrared or red, LED or laser that's, combined with methylene blue to have an effect? Or, let's just talk about lung cancer. What if it was a tumor that was accessible, at least fairly accessible via bronchoscopy? Could not a bronch be done for a patient to, shine light with the combination of these photosensitive molecules as a way to help kill cancer cells? I personally believe they could. Obviously those are more invasive procedures than just standing in front of a light panel. But I'm just saying that, like, if this is a truly safe, and effective potential way of killing massive amounts of cancer cells, and there's no side effects, then we do endoscopies for all kinds of reasons all the time. Whether it be abdominal pain or for screening purposes, and that's considered safe. So if someone has a cancer, would that not also be considered safe? In that particular context, I believe that it could. So when people push back and say, basically, this is for experimental purposes, and this is not going to be clinically applicable, I would say maybe not, maybe it is, and maybe people who are in the research fields who have access to grant funds and the ability to perform studies, or the ability to innovate and find new ways of applying this therapy, then they should, instead of complaining that it's not viable, they should go and perhaps go innovate something and create something for patients that could be used in the short term. But I'll digress. So in this case, they were using these melanoma cells, and this paper is titled "Methylene Blue and Photodynamic Therapy for Melanomas, Inducing Different Rates of Cell Death, Necrosis, and Apoptosis for these melanoma cells according to the methylene blue concentration and energy dose." So again, the dose is important, and the dose is just as important for light as it is for methylene blue. So in this case, I kind of want to pick apart some of these things I talk about in the methods. So if you look at the concentrations, is 0, 1, and 2 micrograms per milliliter was the concentration of methylene blue exposed to a red diode red laser at the wavelength of 660, which is perfect because that's right in the range where that's a maximum absorption of methylene blue, and the power of 100 microwatts per centimeter squared. Energy density was 0 joules to 100 joules, and then later 720 joules. So no, none, a little, and a lot, right? And then they looked at the cell viability. And it says here that methylene blue photodynamic therapy decreased cell viability and increased cell death, necrosis, and apoptosis in drug and light-dependent dose manner, right? So the higher the amount of medication and the higher the amount of light, the more effects on these cancer cells, in particular this melanoma model. Morphologic characteristics of necrosis were observed immediately after treatment, and apoptosis characteristics were observed after 3 hours of the treatment. And I'd have to do the calculation myself, at 100 microwatts per meter squared to figure out how long it actually took to get 100 joules versus 720 joules respectively. But, probably not much longer than an hour, I would guess. And apoptosis and necrosis rates varied with the drug and light doses, with 2 micrograms per milliliters of methylene blue and 100 joules of energy inducing the highest rates. So this is an interesting finding. So basically what they found is that it took a higher dose of methylene blue, but it actually was the kind of the more moderate dose of red light, which caused the highest amounts of apoptosis and necrosis in this melanoma model, which I thought that was interesting. And this is talking about methylene blue photodynamic therapy in melanoma. And it says that two treatments of methylene blue photodynamic therapy promoted the decrease of 99% of the tumor volume and 75% of the tumor weight compared to untreated mice. So this shows the power of these therapies, right? Like 99% of the tumor volume and 75% of the tumor weight was decreased with two treatments of methylene blue and photodynamic therapy. Pretty unbelievable. And I think that that's where, like, most people could say, you know, who even are skeptics, that photodynamic therapy doesn't penetrate as deep as, you know, we want it to, or believe that it does. Although I do believe there's controversy there. But okay, let's limit it to skin cancer. I mean, skin cancer does kill people. Not a huge amount of, you know, deaths compared to, you know, the major ones like lung and colon and breast cancer and stuff like that. But like, bottom line is, like, why, if we have something like this that has relatively no side effects and could have this amount of cancer cell death in such a short amount of time, you know, with limited side effects, why would this not be part of the standard of care, or at least becoming part of the standard of care rapidly? I don't understand. Someone had asked about breast cancer, and we, you know, had seen in other publications where, you know, it's effective against multiple types of cancer, but I did want to talk about breast cancer. So methylene blue photodynamic therapy induces selective and massive cell death in human breast cancers. And I believe in this study, they were using triple negative breast cancer. Does it actually say here? I think in the paper, it did mention that they were triple negative breast cancer cells, but I'll digress. So they were using methylene blue irradiated at 640, okay, and 4.5 joules per centimeter squared of, I'm guessing, irradiance. And so fairly low amounts of red light were used in methylene blue. And I think it's because this is an in vitro study. Maybe they used less light. But the results, we observed that methylene blue photodynamic therapy differentially induces massive cell death in tumor cells, in this case, breast cancer cells. Non-malignant cells were significantly more resistant to the therapy compared to malignant cells. So basically, the healthy cells were not affected to near a degree. Morphologic and biochemical analysis of dying cells pointed towards alternative mechanisms rather than the classical apoptosis. Interesting. Methylene blue induced autophagy modulated cell viability depending on the cell model used. However, impairment of one of these pathways did not prevent the fatal destination of methylene blue photodynamic therapy treated cells. Additionally, when used, a physiologic 3D cell culture model recapitulates relevant normal and tumor tissues of breast tissue morphology. Conclusion of this particular study was, finally, our observations underscore the potential of methylene blue photodynamic therapy as a highly efficient strategy, which could be used as a powerful adjunctive therapy to surgery of breast tumors and possibly other types of tumors to safely increase the eradication of microscopic residual disease and minimizing the chance of both local and metastatic recurrence. Amen to that. So this is actually further down in the paper. I've highlighted some more part of it. And it says here that methylene blue selectively induced breast cancer cells. And this was let's see here. We use the following human epithelial cell lines: MCF7, ER-PR, and HER2 positive. Okay, so this is actually like triple positive cell line. And then they also use this MDA-MB237, a triple negative cell line, and then MCF10A, which is a normal cell line. So let's see if we can take a look at some of these cell viability studies. So this is the amount of cell death is 100% cell death, 0% cell death. So this is using 2 micromoles of methylene blue, and they used the 640 nanometer red light, like we talked about in the methods of the abstract. So we see that at 1 hour, we see no effect at all of cell death on normal healthy tissue. We see some effect, or let's just call it almost no effect, on this triple positive breast cancer, But the triple negative breast cancer, we see an effect even at 1 hour. 20% of the cancer cells are dead. Then at 3 hours, we see some effect on normal tissue. And then we see about 20%, maybe not quite 20% of the triple positive breast cancer cells at 3 hours. And we see about 60 to 70% of the triple negative cancer cells being killed at 3 hours after one treatment of photodynamic therapy, which, with a pretty low amount of light, to be fair. Not a lot of light, if I'm reading that abstract correctly, in terms of the amount of energy put into the system. And then at 24 hours, we see, about some degree of the normal breast epithelial tissue having some apoptosis. And then at 24 hours, we see nearly 80% of the triple positive breast cancer cells being killed off. And then we see a nearly 100% of the triple negative breast cancer cells were killed after 24 hours with one application of methylene blue and one application of red light therapy in this particular study. Pretty unbelievable. And then this is looking at a high dose of methylene blue, 20 micromoles of methylene blue. And again, we see kind of like at 1 hour, look at the triple negative. Wow. Nearly 100% of the triple negative at 1 hour. 3 hours, not a whole lot more. And 24 hours, I mean, you can see that if you probably really zoomed in, you can probably see maybe it went from like 85 to like 90 to like 95% or something like that. But bottom line is high dose, it seems like it kills it faster. And then you see that the triple positive has more of an effect at 24 hours than it does with the 2 micromoles and respectively at various times. We do see it at the higher doses, which, this is likely going to be much higher than the 0.5 to 4 milligrams per kilogram dose, kind of safe doses that are recommended by most of the research that I've seen to achieve this amount of micromoles concentration. But you do see, some, decent amount of the normal cells were actually affected and killed by this therapy as well, with the giant doses. With the lower doses, not so much. Using a lower concentration of MB, we detected the normal cells were even less sensitive to methylene blue. Photodynamic therapy is important to note that this dose still induced massive cell death in the malignant lines. So I think this highlights that, yes, higher doses are going to have higher effects on the triple negative and triple positive breast cancer cells, but the lower doses also created a massive effect. And remember, I'm probably going to close off here pretty soon because we've already been an hour and 15 minutes in. But what I would say is that, remember, this is methylene blue and red light therapy by itself. Okay, by itself. This is not methylene blue and red light therapy plus keto, plus HBOT, plus DAWN, plus all the other amazing compounds that have been shown to have a synergistic effect with metabolic therapy, right? And just to be clear of how we believe, or how the researchers believe, that this photodynamic therapy actually works, is that it increases reactive oxygen species in a dose-dependent manner to create oxidative stress, right? And in the healthy cells, there's not much of an effect because they have, the healthy ability to handle that. The cancer cells, they have their shields up too, but when we take the shields down, right, we are effectively leaving them even probably much more sensitive to these type of therapies because the shields are down and they can't protect against even normal amounts of reactive oxygen species, let alone these massive amounts. I'd also say that probably one of the reasons why it has much of a less of an effect on the normal cells and the cancer cells is because methylene blue within normal cells acts as a potent antioxidant. So it's probably sopping up or mopping up the excess reactive oxygen species in the normal cells, where it actually increases them in the cancer cells. But I'll digress. So in the discussion, it says that in this study, we've demonstrated that methylene blue photodynamic therapy induced massive cell death in 2 breast cancer cell lines, the triple positive and the triple negative, with different invasive properties. The highest sensitivity to methylene blue was observed in the triple negative cell line, and this tumor subtype where there are no targeted treatments, and you are relying on conventional chemotherapy for those cancers. This effect is very relevant because triple negative breast cancer tumors are the greatest challenge in breast cancer treatment nowadays. With methylene blue photodynamic therapy was obtained almost 100% cell death of these malignant cells. I mean, we saw it on the graphs, right? Nearly 100% of the cancer cells were dead within 3 hours, let alone 24 hours, right? Let's see here. Our results were significantly better than other ones obtained using photodynamic therapy for treating breast cancer. Other photosensitizers were used in previous studies. So this is showing that photodynamic therapy has been shown in with other photosensitive chemicals as having an effect, but this is the best one ever seen because they were using methylene blue. In our study using methylene blue, there was no dark toxicity, which means there was no toxicity when there was no light shine on the methylene blue, which is one of the features that can increase local specificity and safety of the treatment. One of the advantages of photodynamic therapy over other cancer treatments is the possibility of generating less side effects to patients. Of course, like that should be our first and foremost. We want to not have side effects for patients. Our results demonstrated the efficacy of methylene blue photodynamic therapy in selectively eliminating breast cancer cells. Let's see here, conclusions. When compared to other studies of photodynamic therapy on breast cancer, we have reached a greater efficacy in the selectively killing cancer cells with no MB or methylene blue dark toxicity. Besides, we've demonstrated the differential effects of methylene blue photodynamic therapy in more than one cell line. So it's not just ER positive, PR positive. It's not just ER positive, PR positive, HER2 positive. It's triple positive and triple negative have massive effects in this particular study. And overcoming one of the important caveats in many photodynamic studies use either one tumor type or one other tumor type. So it's showing that it has kind of a pan breast cancer effect for the use of as a therapy. And this publication, Methylene Blue as an Anti-Cancer Photodynamic Therapy Systemic Review of Preclinical Studies, it says that the results of the systemic review support the suggestion that photodynamic therapy with methylene blue helps against different types of cancer, including colorectal cancer, carcinoma, melanoma, etc. And I do believe that this could be a game changer for photodynamic therapy. Oncology seems to be a promising area for methylene blue thanks to its pronounced photosensitizing action as a result of disruption of pathological cells, aka cancer cells, under the influence of light. This effect occurs because of the phenothiazine chromophore, aka that type of molecule that absorbs the light. It absorbs in the light of 630 to 680. We've seen the graphs, which can generate reactive oxygen species and lead to cell death. Furthermore, methylene blue selectively accumulates in cancer cells. These properties make the photodynamic therapy. I'm gonna restart. These properties may be used in photodynamic anti-cancer therapy. And one thing I wanted to kind of finally terminate this particular live stream on is the fact that there are a variety of how do I say this? Very similar to how oral vitamin C or liposomal vitamin C has a modest increase in serum vitamin C concentrations, which means that it probably cannot be used for anti-cancer therapy, whereas IV has like a 10 or even like 100-fold increase in serum concentrations in some cases. The same is going to be seen with either using IV or oral methylene blue, because then the next question is, what is the route of administration that can potentially be effective? And I still think that needs to be worked out. But I did find this paper that was published in 2000, and it says here that they use either oral or IV, same dose, 100 milligrams. Okay, that's a pretty decent dose, IV or oral administration. And it found that after 5.5 hours, the serum concentration was 9 nanomoles per minute per milliliter versus 137. So that's a huge, more than 100-fold increase in the serum concentration using IV versus by mouth with the same exact medication, right? Same exact medication, same exact dose, just IV versus oral. So my belief is that in order to kind of achieve these doses that are necessary or have been shown to be effective in some of these preclinical models with a variety of cancers, you're going to need likely IV methylene blue as the way to administer this. Does that mean oral is absolutely useless? I don't know. I mean, people have to do the work and figure out if it's useless or not. My gut tells me it's probably next to useless for these purposes. And then the next question is, how to get the light where we got to get it. We know the wavelength, and we also know that, we know for the most part what wavelength, right? So a lot of the panels that we see in commercial applications could likely be used as long as they can affect the target tissue, right? The penetrance of the light, which is going to be an area of discussion and controversy that I would like to try to have an expert opinion about that from a light engineer. So I'm reaching out to him, or having my colleague reach out to him to see if we can get him on as a podcast, and then dispel some of those myths and kind of, make photodynamic therapy much more, how do I want to say it? Much more doable for a variety of people, even potentially from home using a home panel. So with that, I'm going to close out. This is kind of the last piece of the puzzle, putting together red light therapy for cancer and photodynamic therapy for cancer, kind of with the grand finale being methylene blue photodynamic therapy and its effects on a variety of cancers and its potential to be used later on. I'm going to try to answer some of these questions here, if I can see them. Oh boy, a lot here. Is methylene, so methylene blue is light therapy? Methylene blue is a medication. So it's a medication that can be used either by mouth or intravenously, and then it works with light therapy. PDT, what light is used? So I have a couple of different videos before this video talking about photodynamic therapy, and photodynamic therapy can be used depending on the photosensitizing molecule, right? So if the photosensitizing molecule is absorbing in the UVA range, we'd use UVA to activate that molecule. If it's activating in the blue range, we use blue. If it's activating in the red range, we use red or infrared, right, respectively, depending on the molecule used. And in these cases of methylene blue, it's most effective in the kind of the red range. Let's see here. Does anyone know where Dr. Casey practices in person? Dr. Casey doesn't practice in person for his functional medicine business. He practices via Zoom because I don't have a physical location. I live in Florida. My medical license is in Florida. And so you'd have to be physically in Florida at the time for the consultation to happen for me to practice medicine. I can do educational consults from anywhere in the world, that being said, where I don't act as your doctor. Methylene blue directly accumulates in dysfunctional cells, such as cancer cells. Yeah, it's pretty cool, huh? Combination of red light therapy, blah, blah. Sorry, I cannot follow well. Are you saying that there may be possibility of enhanced benefits if you take methylene blue to get ultraviolet, red light, and near-infrared light? Yes, absolutely. I don't know about UV. I don't know of methylene blue having any absorptions in the UV range, but in the red range, strongly. I mean, its peak absorption is about 660 nanometers, which is right in the middle of the red range. So absolutely, there is enhanced benefits for certain conditions potentially. Yeah. So yeah, Russell Reeder is the melatonin guru in the world likely, and the dosage that I've heard him or his colleagues recommend are crazy high. You're talking about 2 to 6 grams broken up throughout the day. That is gigantic, doses. I have not seen that being recommended by conventional, or not conventional. Of course, conventional oncologists aren't going to recommend it, but integrative oncologists, I have not seen use that high doses. I've listened to Russell Reeder. I've read his papers. I do believe that there seems to be no obvious side effects, even at very high doses of melatonin. So it's probably safe. It's just that how do you get that much into a patient? That's a great question. And what effects does it have? Is there any negative effects? I would be curious. Let's see here. I use methylene blue with proton radiation. It would greatly enhance regular radiation using the use of photons, but with protons, it appears to cause diffusion and change in the Bragg peak. I'll be very frank with you, Access to, I have absolutely no idea what Bragg peak is, nor really, I'm not a radiation oncologist, so I can't really say that I know exactly, the difference between the various radiation therapies. But so it seems that what I'm getting is that methylene blue with proton may not be synergistic. Let's see here. FDA needs to move these treatments forward and fast and furious. Absolutely, they need to. We need to clear house and get real science. That doesn't necessarily mean billion-dollar profits through science, through the proper channels and approved. For how long in the red light is that breast cancer study? Yeah, so John had asked for how long of the red light in that breast cancer study, and what I'd say is it was calculated in joules per centimeter square, right? So it says 4.5 joules per centimeter square, which is a very, very low amount. I want to make sure I can go through the methods of that study to make sure that is the case, but it would not be very much time. Boom, double boom, ambient sunshine all day long, every day for a week. PBM shouldn't be used if you're not keto, correct? I'm not saying that. I'm not saying photobiomodulation should be used if you're not keto. I think there's a lot of benefits to photobiomodulation if you're not keto for preventive medicine, as well as potentially like a standalone treatment, as we've seen in one of the first videos I did on photobiomodulation for cancer. But I think it could be dovetailed into metabolic therapy because it lowers blood glucose by itself, red light therapy, right? So that could help with your GKI, as well as enhancing, potentially ROS within cancer cells. When you add methylene blue with photobiomodulation, there's like an enhanced effect of photobiomodulation and methylene blue. So I think that these could all be synergistic, is what I'm trying to say. I was stunned when Dr. Cruz said loss of smell is recovered with red light panel during COVID. Yeah, I guess it's stunning if you don't have a lot of faith in red light therapy. Red light therapy is very powerful. It's very regenerative. If you're regenerating mitochondria and energy production, then it makes sense that some of those cells can be salvaged potentially, or even regenerated, right? Can we self-administer IV methylene blue with some training? Yeah, I can't go as far as saying that's a good idea. I think it should probably be done by a medical professional with sterile technique and, et cetera, et cetera. Now, could that mean that you couldn't have like one of the IV therapy clinics that like come to your house in a van or like come and set up shop in your house, do it? Absolutely. Would oral be more effective in brains because accumulating brain tissue? Now, methylene blue accumulates in tissue, so it doesn't matter if it's oral or IV, is my understanding. The molecule itself accumulates in mitochondria, and since there's so many mitochondria in brain tissues, that's why it would do that. 2 grams, holy God, I thought 50 milligrams was a high dose. No, matter of fact, so I've used methylene blue personally, like in multiple contexts and using multiple companies. So like one of the major companies in the health space, the mitochondrial space, the biohacking spaces, Transcriptions uses ultra low doses of methylene blue, not even close to the like effective doses used in the studies. Doesn't mean it's bad, it just means that it's not at that level. And then even like I've used like mg per kg, even 2 mg per kg dosing for myself orally, but I still think it's going to have to be that amount of dosing IV to get the concentrations you need in the blood to have the effects at the cancer cell site where we want to have it. All right, well, I'm going to digress and say that this was a really fun, micro series on red light therapy for cancer, photodynamic therapy, methylene blue. It all dovetailed in nicely. I'm going to continue the series on ways to lower blood glucose, ways to inhibit glycolysis, and ways to enhance metabolic therapy. So with the next coming videos, if you have any questions, please leave a comment. If you want to reach out for a consult, we have my emails in the description of every video. And until next time.